Next, Casey's going to introduce our speaker, but first I want to make a comment. If Dr. Rob, Dr. Rob's next, right? If you'd like to come up. So I always want to stand up and say something about Dr. Rob because he has been our sidewalk consultant at camp since camp's inception. So he has been at every camp as long as I've been at every camp. And so we really appreciate his efforts. So he goes around, and when families have questions at camp, he answers them, and you'll see him doing all sorts of things at camp. Joining in, and most people probably know already, but doing handstands across home plate, and all sorts of other, playing with the water games with the kids, and all sorts of other, and archery. And so we always give special mention to our sidewalk consultant. And Dr. Eric Wallace joined us as a sidewalk consultant last year, and he's here again this year, so we'll see him. And with that, thank you so much, Dr. Rob.
All right, well, welcome again to Dr. Robert Hopkin. Dr. Hopkin is a professor of clinical pediatrics at Cincinnati Children's Hospital Center, and he's boarded in pediatrics and genetics and sees patients of all ages, so children and adults, and he has a long-time relationship with the NFDF. We're happy to have him here. And those of you who have been to camp before know about the Fab Shop, where you get to help the adults or other willing children to get all made up, all sorts of colors, like you're going to a football game. And Dr. Hopkin has committed to the Fab Shop by growing out his beard so that there's more landscape this year. And if that is not commitment, I do not know what is. So welcome to Dr. Hopkin.
I am very thankful to be here, and just for the record, the reason that I keep coming back is that I have Peter Pan syndrome and I refuse to grow up, and I like to play. Okay, so we're going to be talking about kids with Fabry disease. There are not thousands of patients recorded with this, and there's not good longitudinal studies, so there will be some limitations. But I think it's a really important topic. So my relationships, most of what I say is going to be about kids with classical Fabry disease. The biggest reason for that is that nobody has studies kids with non-classical Fabry disease. The dogma is that they don't have anything that we can find, but the bottom line is that we don't know what we would find until we look. Okay, so Fabry disease starts very early. If you look carefully at the tissues in the placenta or in the kidneys, prenatally, you can find storage. So that's the start of the abnormal physiology. As we get older, the numbers that were previously given are when we ask adults, so when did you first get this? And that's not the same as when you ask kids or when you ask families who still have kids. That shifts it down some, and we'll talk a little bit about that. But in the first couple of years, if you do a careful eye exam, if you just go see an ophthalmologist and say, I want you to check this child's eyes and don't give them any other information, you're not likely to find anything. If you say, we have a family history of Fabry disease and the insurance won't let us get a genetic test, so can you look for corneal whorls? Then a lot of times you can find it that early. We'll also see GI symptoms before age 2 quite frequently. That can be fussiness that's related to the abdomen, bloating or distension, or recurrent diarrhea are the main things that we would see with that. And then decreased sweating and fevers that are random when the child isn't actually infected with anything. Sometimes we'll see kids fussing and we interpret that as pain, but that's just our best guess about why the kids with Fabry disease tend to be more fussy than the kids without. It's probably right, but it's hard to ask a baby. Older kids, you'll start to see other things. So the older kids can tell us that they have pain. They can tell us where the pain is. They can tell us that they have abdominal pain. And we have some data that indicates that, particularly for the boys, we see decreased growth rates in boys with Fabry disease. So they tend to be smaller, not necessarily than average, but smaller than typical for their family. And that doesn't happen to everyone. You see decreased sweating and decreased ability to tolerate high temperatures or to tolerate vigorous physical activity. And then it gets more and more as you go on, and I'm not going to go through the rest of this in the interest of time. This is something showing the difference between when boys and girls first have reported these findings. So I think it's interesting in this slide that the white line is the females and the dark line is the males in each of the boxes. And the conclusion here is that the boys have onset earlier, which is certainly true for the abdominal pain, diarrhea. Looks like it's clearly true for the fatigue, but there's a lot of overlap. There's not a huge difference in early childhood between the boys and the girls as far as when do they start having problems. The intensity is often quite different, but the disease starts early in both sexes. So this is a study done by Dawn Laney and her group. It's a small study. So the stuff that I previously showed is when we do passive ascertainment, meaning we wait until the family notices or until the patient tells us that they have a problem, and then we find it. And then we pat ourselves on the back saying, boy, are we good doctors. So what Dawn did that was different than that is she got kids that were born and were prenatally known to have Fabry disease or were in a family so they had at least a 50% risk of having Fabry disease, and looked at them carefully from the newborn period and had paperwork for the families to fill out to specifically look for it. This is active ascertainment. Can we see if there is something going on here? And it shifted things a lot. The average age of first symptoms reported in kids, while they're still kids, if we just wait to notice it, is 5 to 6 for boys and 9 to 12 for girls. In Dawn's study, the average age of first symptoms was 18 months. That's a big difference. The earliest symptoms were 8 months. That's also kind of jaw-dropping. It's like, wait a minute, this doesn't start that early, but it does. Now, to find that, they had to use validated scales. They had to use active monitoring. Do we need to do that for everyone? We don't know, but I think that that's a really important message. Okay, this is looking at biomarkers. This is another thing that we don't understand as well as we would like to. So I just said that you can find evidence of storage in the prenatal period. At birth, which is the lowest little bar on the screen, or where the healthy one is, at birth it's low. The lyso levels, lyso-Gb3 levels or GL3 levels are low. And the thought has been that that goes up slowly and that in adults you see these very high levels. So the normal level of lyso-Gl3 is less than 0.3. And in a classical patient, it can be over 150. That's a huge difference. But we always thought that that built up slowly over time, but it doesn't. It goes up very rapidly so that by 12 months, you're really at about the level that you would expect for an adult. It might go up or down a little bit after that, but it's really going to go up high, and then it kind of stabilizes. And that also tells you something, because people have said, well, we're gonna monitor this over time, and if it crosses this threshold. Well, if you're over 2 years old, it's probably not going to change. It's either normal or abnormal, and it can be mildly, moderately, or severely abnormal, but it's usually going to stay pretty stable, at least based on the most recent data that we have. So now, we talked about kidney disease a little bit, and kidney disease is a big deal in adults, and heart disease is a big deal in adults, so we need to know about that in kids. Storage does take place in kids. You can see the storage in these micrographs, and these are pretty young children. What you don't see in kids really is renal failure. If you do see high levels of proteinuria or renal insufficiency in a child, the child should, 1, be treated for their Fabry disease, but 2, evaluated by a good nephrologist for other kidney diseases. Most of the kids with true renal insufficiency or high levels of proteinuria in childhood have something else in addition to their Fabry disease, usually an autoinflammatory kidney disease. This is looking at the microalbuminuria. You do see that in kids, but high levels of proteinuria you should not see in kids with Fabry disease. So if you do, that needs to be evaluated, not just assumed to be the Fabry disease. It might, in some rare cases, just be the Fabry disease, but it should be evaluated. Okay, cardiac disease. So we do see abnormalities in kids. The earliest one is sinus bradycardia, and that one starts in childhood, can start as early as 6 or 7. A lot of kids will have it by the time they're in their early teens. You will see some other evidence of heart disease in kids, but not much. When we looked at 350 patients who were all pediatric, we had less than 1% with significant abnormality on an echo. So it's not super common, but if we look carefully, if we do cardiac MRI with T1 imaging, it will be abnormal. If we do rhythm evaluations and we count the bradycardia as a significant finding, we will find that as well. So we do need to monitor these things, and the idea is that we want to treat these organ systems before you have before you have dysfunction of the organ. Because by definition in this disease, if you have heart dysfunction or kidney dysfunction, that's irreversible. You can't get it back. So cardiac involvement, on the other hand, within the normal limit. So if we look at heart size, but in the normal range, there's a skewing of the kids with Fabry disease to the higher parts of the normal range compared to just the middle of the normal range. Yes?
I have a question on the correlation of POTS and Fabry.
Of what? POTS? That is a really good question. It seems likely that it would correlate because low blood pressure is common in Fabry disease, and low blood pressure and abnormal regulation of blood pressure with activity is a key driver of POTS symptomatology. However, as far as I know, nobody has studied that, and I know nobody has in kids. So likely in theory, but should be looked at. Okay, cerebrovascular disease. So the white spots that were mentioned earlier in the brain are sometimes seen in kids, meaning there is some cerebrovascular abnormality. We don't see a lot of strokes. So this is showing some white spots in fairly young children. We don't see a lot of strokes. TIA has been reported. When we looked at the 350 plus kids, just to see at baseline how many kids with Fabry disease have the common manifestations, we found 0 with stroke. Okay. However, we should not conclude that they don't get strokes. I have seen in my practice 3 people who had strokes in childhood. The youngest one was female. She was 9 when she had a stroke. She was worked up thoroughly. No other cause for the stroke was found. And when I saw her, she was an adult. Had not had another stroke, but did have a retinal infarct because of a similar event, but in the eye, not the brain. I have had 2 other patients with strokes. One was 14, the other one was, I think, 17. And I am aware of 5 or 6 additional children with Fabry disease who had strokes. It can happen. We should be aware of that. It's a rare complication. Looking in the medical literature for complications of rare disease, it's hard to find things with an incidence of less than 1%. And stroke, active heart disease, and renal insufficiency are in that level for kids. Ocular findings are common. We see the corneal whorls. I got these out of order. Hearing, okay. Hearing loss can be detected in kids. It's, again, not super common, we think. One of the challenges with it is that we don't check very often in kids. So they get a newborn screen, and if it's normal, then unless somebody notices that they can't hear, we don't go back and look again. We know that there can be some differences from normal, usually not at a level that stops them from having normal conversations and being able to do normal things. But is there hearing loss or not? There probably is some. Okay, now eyes. Corneal whorls can commonly be seen in children with classical Fabry disease. We don't know how common they are in children with non-classical Fabry disease. Retinal problems with the retinal tortuosity, blood vessel tortuosity, and embolic or thrombotic events in the retinal blood vessels. We don't know how common that is. We do know that it can occur. I had always kind of just ignored that and hoped that it wouldn't occur until I had a young man in my clinic who I saw him, he looked good. We talked about how he was doing and the importance of treatment for Fabry disease. He was getting up to leave, and he said, wow, this eye won't focus. And I said, sit down. And I pulled out the ophthalmoscope. I looked in his eye, and there was a blood vessel that was more dilated than it should have been, and then it just stopped. And I called the ophthalmologist, who happened to be one floor above us exactly, and then we walked him up there, and they put TPA into that and opened it up and saved his vision. But he would have had a blind spot if he hadn't been in our clinic when that happened. So he was very fortunate. We do not know how often that happens. We know that it can. Okay, quality of life for kids with Fabry disease. So talking about treatment for kids with Fabry disease, there are lots of people who argue that we should hold off as long as we can. And there are a number of reasons that are brought up for that, but the one that's most commonly used is that we want to maintain normal childhood. I got news for you. It's not normal. From 18 months, according to Dawn's study. So we don't need to do that. And in there's only limited information, and it's mixed with information from other diseases. But the data that we have indicates that children who are treated actually go to school more often and have better quality of life than the ones who are untreated, at least for classical Fabry disease. Again, no information on non-classical Fabry disease. That's been evaluated and reviewed. So, quality of life. We see neuropathic pain in a majority of males and nearly a majority of females. We see GI symptoms early and often, much more common than in the general population. We see skin manifestations, which in this case includes decreased sweating as well as things like angiokeratomas. And then you notice that at the bottom of this, on the right side of this, heart, renal, and cerebrovascular, there are some signs, but not nearly as much. Now, we do need to monitor those organs, and we need to pay attention to them because preventing those major organ problems is one of the key goals of early treatment for Fabry disease. And so we need to measure that. But we also need to measure the things that we're paying most attention to, which is the quality of life for the kids. So we need ways of assessing pain that's not, hi, how are you feeling today? Oh, good? Great, then we're done. Okay, let's just keep treating you. We need to use pain scales, and I know it's a pain to fill out all of those forms, but honestly, that's the best way we have to measure the disease impact in kids right now. We're looking for better ways, but the forms that we give you are the best that we have. So this is looking at sweating, and sweating is really important. Although my patients who have never sweated before and we start them on treatment, they do not view sweating as a blessing. They're like, oh, this is so gross. How can you live like this? Okay, this one is looking at quality of life. The values across the bottom, the lower that number is, the more significant the finding is. And this is the PEDS-QL, which is a sort of global quality of life scale for children. It's been used for lots of diseases, and we used it for kids with Fabry disease. And this shows that in every category, males and females, it was lower than expected. and substantially. Now, that was kids' average age of about 11. So we need to pay attention to this. We don't want to wait as long as we can because we don't know what additional harm is being done. We don't know where the cutoff is for things we can treat and get a good outcome and when it becomes irreversible and eventually self-sustaining damage to the disease, to the kids. Okay, so conclusions. Storage in Fabry disease begins prenatally and is progressive. Neuropathic pain is very common. GI symptoms are very common and are very socially important. I didn't have time to go into that. The histology on the kidney disease is abnormal from childhood. Cardiac involvement is not as easy to find, but as we are refining the ways we can look at it, it is becoming evident that that's also early impact. Cerebrovascular and oculovascular disease are rare but do occur, and hearing involvement we know is seen, but we don't know how commonly. Pediatric patients from the beginning, if they have classical Fabry disease, have an impact on their quality of life. And so we need to take that into consideration. This is some quotes on the impact that Fabry disease had on some people in childhood. First one is a teenager when he said this. He said, "I just thought I was a wimp. I couldn't handle life and keep up with everyone else." He thought the problem was with him and his mental toughness. And then he got the diagnosis given to him. He said, "I feel better knowing that there is something really different, that there's a reason and I'm not just weak." Then the other one was an adult when he said this, but he was a man going into a clinical trial for Fabry disease. So I'm doing this to help the next 12-year-old to not experience what I did growing up. And then the last part of it, he said that seriously. He wasn't tongue-in-cheek. If we get good treatment for them, it will be worth it, even if this kills me. Meant a lot to him. It's one of the reasons that I am highly motivated to push this. So what are the implications of all this? There's risks to starting treatment, infusion reactions, time taken away from childhood, medicalization. We have to consider that. There are also risks to delaying treatment. You have disease progression and you lose the reversibility. There is benefit from at least some of the current treatments in childhood. We need more study for some of the emerging treatments in childhood. And the benefit is highest with earliest implementation. And we will stop there, and I don't think I have time for any questions.
1 minute.
Oh, 1 minute. One question. Yes.
I have an 8-year-old, and as far as what you mentioned about the eyes, I only remembered hearing about the little pattern on the cornea. But now that you brought that up, it made me question if that's what's going on with him, because he's constantly rubbing his eyes and going like making movements with his eyes, like trying to focus his vision or something. But then the couple of years that we lived in Pennsylvania, they said that he needed glasses. When we moved to Florida, they said he didn't. And then they have me bouncing back and forth, and I don't know whether he needs it or not, but I do see him often rubbing his eyes or doing like weird movements.
So I don't know what to tell you on that. The vascular things that I was talking about that do affect vision are usually not something somebody feels. So you wouldn't rub your eyes for that unless you were having some blurry vision, which would be quite uncommon. the same kinds of nerve things that happen in hands and feet can happen in other parts of the body. So that could be creating some need to rub the eyes, but also normal things of childhood are still normal in kids with Fabry disease, and rubbing your eyes or having some itching around your eyes or discomfort in your eyes is quite common as just a general childhood thing, especially if there's any evidence of allergies or something like that. But that's the best answer I can give right now. Talking to the ophthalmologist about the things that can happen with Fabry disease is probably a good idea, so that they can, because they'll know if they look it up to look for corneal whorls, but there's not much emphasis on the tortuosity or the thrombotic lesions in the eye, which are probably more important from a vision standpoint.
And I tried to bring it up to the pediatrician, but they brushed it off because they said that the little test that they do, where he covered one eye and the other, that he did fine. So they literally brushed it off.
Yeah, and it is a standard recommendation to get a formal evaluation from an ophthalmologist every year for people with Fabry disease, so you could point that out to the pediatrician and ask them to send you. And they should agree to that.
Okay, thank you.